Hello students, welcome to Distinction Learning Platform, and on this platform you find revisions, tests, quizzes, a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated with our upcoming videos. Make the story short, let us begin. In this video, we're talking about GI bleeding, okay, and this is under clinical session, okay. So now the question is, what is GI bleeding? What is GI bleeding? So GI bleeding basically is just a bleeding that can happen in part in the gastrointestinal tract, starting from the esophagus up to the anus. So what is GI bleeding? So GI bleeding, we are saying bleeding in what? In any part of GIT, gastrointestinal tract, okay? Starting from where? So starting from esophagus. So let's just use E as esophagus to make more space, okay? Starting from what? Starting from esophagus, okay? Starting from esophagus to what? Anus. Let's just say A to A, E to A, okay? From esophagus to anus. That is what we call GI bleeding. Now, this GI bleeding now, it is a very, very important part. Why is studying about GI bleeding? Because something that can cause what? Like in mortality, increasing the mortality rate in the population, okay? Now, how can you classify this bleeding? Okay, so bleeding can be classified according to different classifications, but we'll pick the most important classification, which is anatomic classification. But before we go into anatomic classification, let's talk about the other classification that they use. What is that? So we can classify the GI bleeding according to the duration. If it is according to duration, we're going to say what? We know this is acute or chronic. Okay, so acute or chronic bleeding. Okay, the bleeding can be acute or chronic. If you talk about acute, it can happen in hours to days. If you talk about chronic, it's starting from weeks to months. That will be chronic GI bleeding. That's according to according to the duration. Okay, what else apart from that? Okay, again, it is very, very interesting to say the bleeding can either be you can see the bleeding, or you can't see the bleeding using your naked eyes, or maybe you can't find the source of bleeding. So it can also be classified according to the if you are able to see the bleeding. Okay, that is also according to the clinical classification. Okay, so what are we saying? If you can see the bleeding, what can you see? What can you say? That is what we say ovate type of GI bleeding. If you are able to see either from the mouth or through the anus, like that, if you are able to see, that is ovate bleeding. What else apart from that? If you can't see the bleeding using your naked eyes, okay, so if you can't see the bleeding using your naked eyes, how can you classify that one? We can say that is we call it occult. Okay, occult bleeding. If you can't see, so occult bleeding, basically we are going to use something. Okay, there are some certain conditions that we'll talk about that can present with occult bleeding, whereby someone is having symptoms of shock, where they are bleeding, but you can't you can't see the bleeding using naked eyes, but they are bleeding. Then that's what we call occult bleeding. But we talk about the something that we call it is fecal occult blood test. That one is going to be positive under occult bleeding. We'll talk about that. Okay, that's the thing that you can use if you can't see the bleeding. Now, what else? Apart from that, there is also another one that we use. Okay, we can use what we call obscure bleeding. Obscure bleeding is what? If let's say you can't, it's either you can see the bleeding or you can't see the bleeding, but you can't identify the source. That is what we call obscure bleeding. So what am I saying? Obscure bleeding is either overt or occult, but you are unable to find out the source. Using what? So how do you find the source of bleeding? Using what? Is some certain instrument, like using the upper endoscopy or the endoscopy or the colonoscopy, if you are using those normal instrumental procedures that we use so that you find the source of bleeding, but if you can't see the source, then that simply means that is what? Obscure bleeding. Okay, so obscure bleeding, that's why I said to say it is either what? It is either you can see the bleeding or you can't see the bleeding, but you are unable to identify the source using what? Normal procedures that we use to identify what? The source of what? Bleeding. Like what? Endoscopy and colonoscopy. Very, very important part. What else? So apart from acute, chronic, overt, occult, and obscure, there is also another one. Okay. According to what? Severity. So also bleeding can be classified according to what? Severity. We know if it's according to severity, we are going to say mild bleeding, moderate bleeding, and what else? And we have now severe bleeding. Okay, those are the classes that they use sometimes. Okay, they can use acute or chronic, overt, occult, or obscure, or they can use moderate, mild, moderate, and what? Severe type of what? GI bleeding. Okay. So since we've understood those classes, those like simple classes, okay. Now, before we go to anatomic classification, let's understand something, okay. There are some things that are very, very important when it comes to what? GI bleeding, which is what? Severity assessment, okay. How can you assess that? Okay, this bleeding is what? Is so severe, because it's very, very important, okay. So let us look at those parameters that they use, okay. What is that? So the first one is, if you look at the pulse rate, okay? If you look at the pulse rate, okay, let's just say PR. If you look at the pulse rate, it is going to be what? Greater than what? 100 beats per minute. So if you look at the pulse rate, someone is breathing and the pulse rate is greater than what? 100 beats per minute, which is tachycardia. What are you going to say? You are going to say that GI bleeding is what? Severe or moderate. Okay, so severe. You need to intervene. That's why severity assessment is very, very important. So what am I saying? So if you see the pulse rate greater than what? 100 beats. Let's just use small letter. Beats per what? Beats per minute. Okay, 100 beats per minute. Okay. 100 beats per what? Per minute. Then that's a moderate or severe type of GI bleed. What else do they use? Okay. The other thing that they use is what? Is systolic blood pressure. Okay, SBP. Okay. Systolic blood pressure, if it is less than what? If it is less than 90. If it is less than 90 millimeter of mercury, what do we think? It is what? The bleeding is severe or moderate. So these are very important parameters that you need to understand. What else apart from that? There is also another parameter which we call, like if you do the general exam like that, then you find out to say there is altered mental status, then it is also considered as what? One of the parameters for severe type of GI bleed. Let us say altered mental status, okay? If someone having altered mental status is also what? One of the important parameters that they use to assess the bleeding. Also, if you look at like the bleeding is not stopping like that, it is prolonged. The bleeding is prolonged for like for certain hours or maybe for days. Then we're going to say okay, that is also a severe type of what? GI bleed. These are very, very important. You need to intervene if you see something like that. Okay, yeah. So that was the very, very important thing that we needed to discuss. Okay, then let's go to another important. So this is the something that they like what asking. Okay, anatomic classification. One I didn't talk about here. Okay, anatomic classification is one of the important class when it comes to what? GI bleeding. Let's start with this one. So now the question that you can ask is that how can you classify GI bleeding according to anatomic classification? Because if you use anatomic, basically you are going to use a certain anatomic structure that's going to separate the two types of what? GI bleeding according to what? Anatomic classification. What are those? Okay, what is that structure that they use? So they use what we call the ligament of what? Treads. So what do they use for anatomic classification? They use this reference, okay? They use this reference as what? Ligament of what? Treads. So let's just say L, ligament of what? Treads. Okay? Ligament of what? Treads. Z, sorry. Okay? Ligament of what? Treads. So ligament of treads is a structure that comprises of what? Or fibrous structure that contains what? connective tissue and what smooth muscle. What does it come? What does it come from? Okay, what's the origin of ligament of Treves? It comes from what? Right crest of the diaphragm there. So it comes from the and insert where on the what? On the duodenal junction there, where the duodenum is going to end and where the jejunum is going to start from. That's where what is going to attach itself. Okay. Now, why am I stretching enough under the ligament of Treves? Because the one that's going to separate the upper GI bleed and what the lower GI bleed. Upper GI bleed like this one is above what or proximal to ligament of what Treves. Okay, if you see bleeding starting, the source of bleeding is coming from what? It's coming from the it's coming from the what? The source of bleeding is above the what ligament of Treves, then you are going to consider it as what upper GI bleeding. If it is lower than the what ligament of Treves, you are going to say that is lower GI what bleeding. You need to understand that structure. Okay, very, very important. So in this part, we're going to start with what upper GI bleeding. Okay, upper GI bleeding. So upper GI bleeding is the most common cause of what GI bleeding. So it's about what? How many percentage of upper GI bleeding? It's about what 80%. If we talk about what the occurrence. So upper GI bleeding is more common. It is about what 80%. What about lower GI bleeding? Lower GI bleeding is about what 20%. It's not that common. You need to understand that. Okay. So if we have understood something like that, now what are the parts that are under what GI bleeding? What are the parts? What did we say? So under GI bleeding, we start from where? We start from the esophagus. Okay. Okay. We start from the esophagus. What else? Okay. Then it's going to include the stomach. Okay. What else? It also going to include what? Duodenum. But duodenum up to the what? Second part. Remember that the duodenum is going to be categorized into what? How many parts? There are 3 parts of the duodenum. The first part, second part, and the what? The third part. But the upper GI bleeding, we are going to say that, okay, if we talk about the duodenum, if the second part of the duodenum is affected, then we are going to consider that as what? Upper GI bleed. Okay, you need to understand that. Okay, since we've understood about that a lot, okay. Now, what are the causes? What are the causes of this upper GI bleeding? So that's why now things are going to get what interesting. You need to now you need to pay attention here, okay? That's why a problem for students to, like, if you read the causes, that's why now things get what interesting or hard for a student to grasp, okay? But we're going to make it simple. So the causes, I'll start with what? The most common cause, okay? The most common cause. So the most common cause of what? The upper GI bleed is what? This one. What is this one? PUD. Okay? What is PUD? Do you know PUD? The first most common cause is what? PUD. Peptic what? Ulcer disease. That's a common cause of what? Upper GI bleed. So even if you're not doing anything, if anyone asks you the cause, or anyone asks you to say what's the common cause of upper GI bleed, you're going to say what? Peptic ulcer disease. Now the question is, peptic ulcer disease, how many categories of peptic ulcer disease are there? There are what? 2. There's what we call gastric ulcers and what? Duodenal ulcers. So what are we saying? So we are saying there are 2 categories of PUD or peptic ulcer disease. Okay, there are 2 categories. There's what? There's the one that can be found in the stomach, which is gastric PUD, okay, or peptic ulcer disease, or can what? DPUD, which is what? A duodenal peptic ulcer disease, the one that can be found in what? Duodenum. Okay, these are the most important factors. Now the question that you can ask is that why is someone developing PUD, this peptic ulcer disease? Why? Okay, the question is that it has been related to something important, risk factors. Okay, what are the risk factors someone developing what PUD? You know that. Okay, maybe what if someone is taking NSAID? Okay, what if someone taking NSAID? So what are the risk factors? So this risk factor. So if someone is taking what? NSAID. Okay, NSAID, non-inflammatory steroid or anti-inflammatory drugs, okay? NSAID like what? Maybe they're taking aspirin like that, okay? They're taking ibuprofen, those are what we call NSAID. And if you are taking, they're going to cause ulcers in the stomach or the duodenum. Apart from those drugs, what else? H. pylori, we know that. The other important aspect is what? H. pylori. H. pylori is a very, very important what? Important bacteria that can cause what? Peptic ulcer what? Disease. It has been related to that. Make sure that you need to understand that. Okay, what else? Okay, also, it has been shown that also, okay, maybe alcohol, okay, alcohol intake, okay, can also cause what? This type of what? This type of what? Diseases like peptic ulcer disease, okay? Now, since we know the reason why someone is developing that PUD, so in your history or maybe in your like examination or diagnosis, you need to ask if they are taking NSAID, if they are maybe they were exposed to, like, you need to test for H. pylori, okay? You do that urea breath test, okay? You also ask about the history of what? Alcohol intake from the history. You need to take note of that, okay? So that you differentiate, because there are a lot of causes of upper GI bleeding. You need to be noting that. Now, the question that you can ask is that, what are the important clinical features that you can see? Okay, before you go to the clinical features, what we are saying is like this, okay? What is the pathophysiology of what? Someone developing PUD, okay? The pathophysiology is like this, so it's like this, okay? You know, if you look at the gastric wall here, this is the gastric wall, okay? Up to the what? Duodenum like that, okay? So PUD can either be in the gastric wall there, or in the stomach, or in the duodenum like that, okay? But what could go wrong like that, okay? What could go wrong? It's because of what? Increasing the production of what? Let's write it. Increasing the production of what? Pepsin, okay? Also gastrin can do that, also acid, okay? Also hydrochloric acid. There is increased production of that, and decreasing the what? Protective what? Mechanism. Protective what? Mechanism. So those protective mechanisms, the normal protective barrier in the stomach there, it has been what? Disrupted. Remember that prostaglandins are very, very important in the what? Protective mechanism of the what? Gastrointestinal, I mean in the stomach. If you have decreased levels of the prostaglandin due to what? Maybe you are taking NSAID, then basically are going to develop what? Peptic ulcer disease. Because this normal line, as you can see, this normal line in here is not there, okay? Because someone was exposed to this, maybe H. pylori, alcohol, maybe NSAID like that, okay? Then you're going to be having what? Ulcers here. These ulcers, you're going to have them. Okay, you're going to be having these ulcers up to the what? Duodenum. Okay, if you have these ulcers, then basically you're going to start what? Bleeding. Okay, the reason why you're going to start bleeding is because of what? Remember that in the stomach and the duodenum, there's certain blood vessels that are there, that are prone to what? Bleed if you have peptic ulcer diseases. What is that important major blood vessels? That is what we call gastroduodenal artery. Okay. Gastroduodenal artery is a very, very important artery that is very, very prone in what? Like bleeding like that. So this artery that we are talking about here, okay? Gastroduodenal artery is the one. If you have an ulcer here, then basically this blood vessel is going to start what? To be leaking blood into the what? The stomach, okay? This blood now, it can either come out like that from the mouth, or it can go and they come out through the what? Anus. But basically that is what? GI bleeding. Because of what? Mucosa what? Erosion. Okay. If that happens now, you're going to have two important what? Clinical features that we'll talk about. So what is that? Now, if you are vomiting blood like that, okay, you are vomiting blood, the fresh blood. What do we call that? We call it what? We call this. Okay. The first clinical feature, someone having PUD, severe PUD. They're going to have what? Hematemesis. Hematemesis is what? What is hematemesis? Vomiting fresh what? Blood. Okay? They're going to have hematemesis. What else? They're going to have what? Melena. Okay? They're going to have what? Melena. Remember that this is melena. Okay, this is what? Hematemesis. If you are removing blood through the mouth like that, fresh blood through the mouth, then basically that will be what? that would be what? Hematemesis. If you are removing blood through the what? Anus, okay, then you are going to call it what? Melena. But basically, melena can only come about if you are having what? Upper GI bleed. If you talk about the lower GI bleed, we are not going to be calling the blood that is coming from the anus as melena. We are going to change it into what? Hematochezia. Okay, we'll talk about that. Don't worry. Okay, melena. So we are saying hematemesis, melena. Okay, what other important aspect of this? So we are going to have what? Epigastric pain. Okay, epigastric pain, because someone is having what? Ulcer, so they are going to be having what? Epigastric pain. Okay, epigastric pain, and this epigastric pain is used to what? To differentiate between what? Two important causes of peptic ulcer disease, which is duodenal and what? And duodenal and the gastric ulcer. So if someone eat food like that, if they feel okay because they eat food, then the cause will be what? Duodenal. If they feel relieved like that, relieved. Then if the symptoms get worse, or the gastric pain gets worse if they eat something, what is that? Gastric what? Gastric peptic ulcer disease. Okay, very, very important. So gastric pain is very, very important to what? Clinical feature when it comes to what? PUD, because we're able to differentiate between gastric and what? Duodenal. Okay. Okay. So those are the important clinical features that you can assess as well. Okay. Also, there's also another important aspect that you need to understand is that there's also another term that they use: coffee ground vomitus. Okay, coffee ground vomitus is different from what? Hematemesis. Okay, coffee ground vomitus, basically we're talking about the red blood cells that are what? Partially digested, and they are going to look what? Dark brown. If you remove it from the what? From the mouth, they look dark brown like that. Why? Because the red blood cells were what? Partially digested in the stomach. Okay, and that's the main reason why you're having melena. If you that partially digested what? Red blood cells, they come out through the anus, then they're going to form what? Melena. And what's the kind of melena? It is also what? Dark stool like that. Okay, it's looking dark like that because the red blood cells were what? Digested. Basically, it was exposed to the what? Hydrochloric acid there that convert what? That red pigment hemoglobin into what? Into hematine. That's the reason why it's looking dark, which is out from the what? From the anus, calling it what? Melena. Okay, so that's the important thing about that. So cough ground vomitus, we are talking about the vomitus, or the vomiting that happens, and if you look at the characteristics of that, the color, it is what? Dark brown. Why dark brown? It is because of what? The red blood cells there, they are what? Partially digested, where the hemoglobin was converted into what? Hematine. That's the reason why you need to assess of that. Okay, very, very important. Okay, let's go to another one. Okay, so apart from PUD, then we go to another one. What is this one? What is this one? Okay, this one is what we call what? Esophageal varices. This one. What do we call this? We are calling it what? Esophageal varices. Okay? So esophageal varices, what is that? Okay? You've seen this ready thing, and these are what? Dilated what? Submucosa blood vessels, or submucosa what? Veins. There's what? Dilated and prone to what? To start what? Leaking blood. So what am I saying? Esophageal varices basically is a type of varices that's going to occur in the submucosa what? Veins of the what? Esophagus, and they are prone to what? Start leaking what? Blood. We are saying this can rupture like that. If this rupture, they can start what? Removing blood here. Okay, they can start removing blood, and what? You are going to start what? Vomiting blood like that. Or this blood can go in the stomach, and again you're going to vomit it there, or you're going to what? Remove it as what? Melena. Now the question that you can ask is that why someone is developing this esophageal varices, where the submucosa veins, they are what? Dilated. Okay, why? The question is because of what? It's because of something. Okay, someone is having portal hypertension. Someone is having what? Portal hypertension. Someone is having portal hypertension. Portal hypertension basically is an increase in the increased blood pressure in the what? Portal circulation there, okay? There's increased blood pressure there. Now the question that you can ask is that why someone developing portal hypertension causing esophageal varices? Why? Okay? The reason why someone is having portal hypertension is because of what? It's because of they're having two important things. Why? Why are they having this esophageal varices? Are they having portal hypertension? It's because of this, okay? They are having what? Chronic liver disease. So they are having what we call chronic, so let's just say CLD, okay? Chronic liver disease. They are having chronic liver disease, okay? Basically, we know that is cirrhosis. They are having cirrhosis. If they are having cirrhosis, basically it's going to cause what? The hypertension to the blood pressure to increase in the what? Portal circulation there. Okay, if it's increasing there, it's going to cause what? Esophageal varices. Okay, what else apart from that? There's also portal venous what? Thrombosis. What if there's a thrombus in the portal circulation there, in the portal vein there? Okay, hepatic portal vein. What if there's what? There's a thrombus there. If there's a thrombus, there's the obstruction to the what? Flow of blood. So what am I saying? So let us illustrate using a diagram here. Whatever I'm saying. Oh my God. If this is the portal circulation, what I'm saying is like this. Okay. If this is the portal circulation and this is the liver, like that. Okay. Now the first question is that the first thing that we talked about is what? Chronic liver disease. If there's something going on with the liver, maybe there is liver cirrhosis, maybe someone was exposed to what? Hepatitis, like that, they were exposed to what? Alcohol for a longer period of time, then they end up having what? Cirrhosis. If they have cirrhosis, what's going to happen to the blood that is going to the liver, like that, via the portal vein here, okay? It won't be going through the liver and going to the what? Inferior vena cava. Well, then what's going to happen to that flow of blood? It's going to what? Start going back, causing what? Portal venous congestion. So what am I saying? This blood now, instead of going through that, because the liver is jacked up like that, then it will be what? Going back like that. Going back where? Here. Okay, to start going back to the what? Esophageal what? Submucosal veins there. If it is going back like that, it will cause congestion to the esophageal what? Submucosal veins there. Congestion, it can cause now this dilatation of what? Dilatation of those submucosal esophageal what? Veins. If they are dilated, they are prone to what? Rupture. That's the first thing that I was talking about, which is the chronic liver what? Disease, which is cirrhosis. Okay, what else? We said also, what if the liver is just okay? Then there's just an obstruction here. Okay, there's just what? An obstruction there. Okay, if there's an obstruction in there, basically it will just do the same thing. The blood wants to be going up there, then it will be just what? Going down like that, or going back, causing portal venous congestion. What's going to happen? There will be backflow of blood going back into the what? Esophageal veins there, or submucosal esophageal what? Veins, causing what? Congestion also there. Okay, if there's congestion, then those submucosal veins, they are going to be dilated and forming what? Esophageal varices. That is the pathophysiology of this esophageal varices. It's because of what? Two important things: chronic liver disease and portal venous what? Thrombosis. Two important what? Things. Okay. So now, what are the clinical features of someone now having this? We know that the same clinical features that we can have, okay? We can have what? Hematemesis, okay? Let's just use red. We can have hematemesis. Okay, what about pain? So hematemesis is associated with what? No pain, so painless. So very, very important concept, okay? It is what? Painless, okay? So the bleeding that is occurring is not what associated with what? Pain. You need to take note of that, okay? They are also going to have what? Melena, okay? They are going to have melena as well, okay? Also, they are going to have what? The coffee ground what? Coffee ground vomiters as well, okay? But very important feature is what? Painless. And this esophageal varices, the moment they rupture, is one of the causes of what? Higher mortality in what? All the population, because they are going to bleed severely. Okay, so make sure you need to identify this as fast as you can. Okay, you need to do that. Now, The other important thing that we can we can look at is that also the signs of what chronic liver disease. Okay. Also, the other important things from the clinical aspect, what can you do? What can you look for someone having chronic liver disease? Okay, they are going to have what? They are going to have what? Ascites. They're going to have ascites. Okay, while the abdominal, there is what, a lot of fluid there. Okay, ascites. We'll talk about that in the other video. Okay, what else? Okay, what else? What else apart from that? Spider nevia. Okay, they're going to have what? Spider nevia. Okay, spider what? Nevia. Okay. So they're going to have spider nevia. They're going to have what? Ascites. Very, very important concept. What else? Okay. There's also palmar erythema. Need to know about that. There's also palmar erythema. So these are the important what? Erythema. These are the important what? Indication of what? Someone having chronic liver disease. You look at for ascites, you look for what? Palmar erythema, and you look at for what? Spider nevia. Those are very important indication features for what? Chronic liver disease. If you are suspecting what? Esophageal what? Viruses, you need to take to know that. Okay. So okay, it's a lot. So let's go to another cause. Okay. You've seen this one. This one is also another cause, okay? This one, what do we call this one? Call it what? Mallory West tear, okay? These are the tears that are happening in the what? Esophagus. So what are we calling this one? We're calling it what? So let's just call it MWT. Mallory West tear, okay? Mallory West tear is one of the important tear that can happen and one of the cause of what? GI upper GI bleed. So these tears, they are going to happen on the what? On the esophageal gastro junction there. Okay, on the junction between the esophagus and the stomach there, where the stomach is going to start from there. Okay, the esophageal gastro junction there. So that's why the tears, they are going to start happening there. The question that you can ask is that why someone is having these tears at that junction? Why? The question is, the answer is very, very simple. It's because of what? It's because someone is what? Pregnant. Okay, so it's associated with what? Pregnant what? Woman. Associated in what? Alcoholics. Okay, alcoholics, and maybe it's also associated with what? Smoking. Okay, but most important thing are these. Okay. Most important thing are those alcoholics and pregnant woman. Okay, very, very important. Now the other important thing is that how can they can present it? Can they present with? Okay, they can present it with what? With the important feature here. It is what? There is what we call like continuous vomiting. The way they vomit, they vomit continuously. That's the reason why the tear is going to happen. Someone who is pregnant, what do you expect? They vomit almost continuously. What about alcoholics? Also, those alcoholic people, what do? They vomit continuously. If they vomit continuously, what's going to happen? They are going to tear now on the esophageal gastro junction. So what's the important clinical features here? Continuous vomiting. So they see followed by what? Now they are going to have hematemesis. Okay, vomiting fresh blood like that. Okay, what else? They are also going to have what? Marina. That's the same thing. Okay, what else? They are also going to have what? Coffee ground vomiters like that. Okay, they are going to have that. But the most important thing is what? Continuously vomiting. Then it's going to have to show what? Tears in the at that particular junction. Okay, then apart from that, they are going to have what? Hematemesis, marina, and cough ground vomiters. I explained about these things. Okay, so those are the things that they are going to have. Okay, now the important aspect that you need to have is that This disease or disorder, okay, or condition is what? Self-limiting. It is what? Self-limiting. You need to know about that, okay? So sometimes, if maybe like they deliver like that, they stop taking alcohol like that, then what's going to happen? It will stop. So it's self-limiting, okay? So basically, self-limiting, most of the time we don't they don't intervene, okay? Those are medical cares, okay? They don't intervene. So those are important things. Now, what else apart from this? The other important cause of what? Upper GI bleed. So I'm going to write it here, okay? So the other important causes are here. Like if you talk about it, let's talk about it. Esophagitis. Okay, another important cause is what? Esophagitis. Okay, so esophagitis is a very, very important cause of what? Upper GI bleed, and this basically is going to be identified by what we call price. Okay, so this one is further categorized into what we call this mnemonic price. Basically, esophagitis is what? That's the inflammation to the mucosa of the what? Esophagus. Okay, because of what? Due to what? Because of this pricey thing. Okay. So someone is going to have what this, maybe they were taking P stands for what? Pill induced or drug induced type of what? Esophagitis. What type of drugs that can cause what? Esophagitis? Do you know that? Tetracycline, doxycycline, all those drugs, okay? Like iron tablet, those they can cause what? Inflammation to the what? Esophagus, causing what? Esophagitis. What about R? Reflux. GERD. Remember, gastric esophageal reflux disease. That one where the lower esophageal sphincter is what? It is not closing there. Okay. Basically, if it is not closing, the hydrochloric acid or the gastric secretion will start going up into the what? Esophagus, causing what? Inflammation to the what? Esophageal mucosa. Causing what? Esophagitis. If you go to I is what? Infection. Infection like what? Candida in what? Immunocompromised patient, like basically someone with HIV, then they are prone to have what? A candida or candidiasis. That candidiasis can cause what? Inflammation to the what? To the esophageal mucosa, causing esophagitis. If you go to C, caustic. Caustic basically if someone maybe just took out an alkaline or an acid direct into the mucosa there or into the esophageal mucosa, causing inflammation. That is caustic type of esophagitis. Then eosinophilic. E is what? Eosinophilic. Basically, because of an allergic reaction that was happening in the body and causing an inflammatory response to the what? Esophageal mucosa. That is about what? Esophagitis. Now, the clinical features for esophagitis, they can be the clinical features of what? Gastroesophageal reflux disease. Clinical features of these, all these that we've talked about. But basically, they're going to present with what? Hematochezia, hematemesis and melena. They're going to have cough, ground what? Vomiters. They're going to have that. But in addition to that, they're going to have what? Dysphagia. So things that I haven't written is what? Here they're going to have now dysphagia. What is dysphagia? Dysphagia basically someone is failing to what? To swallow, whether solids or liquids, okay, stuff like that. That is dysphagia. So they're going to have that. What else? They're going to have what? Odynophagia as well, okay? Pain while swallowing. Those are the things that you can look for. Odynophagia, okay? These are the things that you can what? Look for, okay? So that is where under esophagitis, okay? What else apart from that? Apart from the esophagitis, there is also another cause that I didn't write here. Also, we have what we call upper GI cancers. Upper GI cancers, okay? Upper GI cancers like what? We have in the esophagus, we have squamous cell type of what? Cancer. We have adenocarcinoma. As well as in the stomach, we've got adenocarcinoma, squamous cell type of what? Carcinoma, gastric cancer. Okay, those they can cause also what? GI bleeding. So what I'm saying is like this. Okay, what I'm saying is this. Okay, I'm saying to say also upper GI cancer. So upper GI cancers. Okay, they can cause what? Bleeding. Like what? So we are saying squamous cell carcinoma, that can cause that. So like what cancers? Esophageal what? Carcinoma or cancer, and what? Gastric what? Cancer. This can cause what? upper GI what bleeding. So there are a lot of subcategories of esophageal carcinoma or esophageal what cancer, like what squamous cell carcinoma and what else, adenocarcinoma. Squamous cell carcinoma, where can you find it? In the upper esophagus and also mid esophagus. Adenocarcinoma, where can you find it? In the lower esophagus. And here the most common type of cancer in the gastric region there, it is what? Adenocarcinoma. You need to know that, okay? So this they can cause what? Upper GI bleeding. But the important thing is that what type of upper GI do they cause, okay? Most of the time, what did I say? I said to say, if you come back here, we talked about the occult, okay? Occult. So this one, they are going to cause what we call occult bleeding. So what if you can remember what is occult bleeding? What is occult bleeding? Occult bleeding is a type of bleeding where you can't see the bleeding using what? Your naked eyes. Okay. So if you can't see the bleeding using your naked eyes, but they use something which we call FOBT. So I use this one. So they use what we call FOBT. Okay, they use this one. Fecal occult blood test. Okay, so this is going to be positive. If you can't see the bleeding, then you do that test. Okay, you need to suspect something. You need to suspect what? EC or GC. Okay, you need to suspect this. Okay, then the other important thing that you can do, the other clinical feature that you can do someone having cancer is what? Make sure that you understand this one is what? Weight loss. It is associated with what? Weight loss. Weight loss. Very, very important concept, okay? Weight loss. Very, very important. Okay, so yeah, I'm explaining weight loss. So these are the important things. Changing appetites, okay? All those things, they are related to what? Cancer. But basically, important thing is what? They have to have positive weight loss and positive fecal occult blood test. Okay, you need to understand that. But the other also investigation that you can do, someone having esophageal cancer and gastric cancer. Okay, very, very important to take note of that. Okay, so the last one is what? Gastritis. Gastritis or duodenitis, also one of the cause of what? GI bleeding. Okay, but basically this gastritis and the duodenitis basically is inflammation to the gastric wall and also inflammation to the what? Duodenal wall. But that one is going to cause what? Superficial type of what? Bleeding. Okay, and the risk factors for someone having gastritis, do you know that? So maybe someone was exposed to H. pylori, someone is exposed to NSAID like what? Aspirin, all those things that I talked about under what? Peptic ulcer disease. They can also cause what? Gastritis and what? Duodenitis. Very, very important. Also those they can cause what? Upper GI bleeding. So in the next video, we're going to start talking about the what? Lower GI bleeding. Okay? Very, very important. All the best, start more. Wait for the next video.